This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Ariana Parks, physical therapist and your host, and today I interviewed Dr. Hanne Albert to discuss Modic Changes. We talked about what Modic Changes are and their classifications, potential causes, how they are diagnosed and their symptoms, and treatment options. Dr. Albert is known as the Queen of Modic, and she was the first person to hypothesize that Modic changes could be caused by bacteria. And with the help of 2 studies, she successfully demonstrated that Modic changes resulting from bacterial causes can be effectively treated with antibiotics. Dr. Albert earned several awards, and she has been considered as a potential candidate for a Nobel Prize. If you find this information valuable, I encourage you to subscribe to our channel, click on the notification bell to stay updated, give us a thumbs up, and share this with other clinicians if you may benefit from this conversation. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Systems for PT, the do anything, anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi, Hanne. Welcome to PT Pro Talk. How are you today?
Fine, thank you. And you?
Awesome. I'm very excited and happy that we are here today with us. We've been waiting for a while to make this happen, so I'm very excited for our talk. So let's get started. Just start telling us a little bit about yourself and your background.
Yes. Well, my name is Hanne Albert, and I'm originally trained as a physiotherapist. And I worked as a physiotherapist for some years, and then I continued to work into research. I did a Master of Science in Public Health, and then I continued on doing my PhD at the University of Southern Denmark in medical science. And then now I work at the Modic Clinic in Odense as the medical director. And I also am a professor at Rush University in Chicago in the United States.
Very good. And so what is your history with Modic Changes? That's going to be our topic today.
Yes, the history of Modic Changes is, I first identified Modic Changes when I did my PhD. And when the patients came after the disc herniation, the 1 year I wrote my PhD about conservative treatment of disc herniation. Had to do different kind of exercises, which was very, very unusual then. Today it's normal standard, but it wasn't then. Then it was surgery. So I was, for a long period, not a very popular person. So, and then I saw that half of the patients who came to their 1 year control, they had developed Modic changes in the vertebra exactly above and below the previous disc herniation. And that's what started my research into Modic changes. And also that they started out with having leg pain, as you normally have at a disc herniation. And now they developed lumbar pain, which I didn't have any lumbar pain before. So I thought, this is a strange connection. They have Modic changes and lumbar pain. So that was in 2001. So it's 22 years ago.
Oh, wow. So it's been a while that you've been studying the topic, huh?
Yeah. It's been, I was a young researcher then, and I had a totally different career planned. And then I saw these Modic changes and my life changed to a totally different direction. So, but that's how it is.
Yes. We never know which direction we're going to go.
That's true. Yeah.
Yeah. So let's start defining. So what are Modic changes?
Modic changes are changes in the vertebra. They are called Modic changes. It's bone edema, and you can have bone edema in your hip, in your ankle, in your elbow. But when you have bone edema in the vertebra, it is called Modic changes, and that's because Dr. Modic defined them in 88, 35 years ago, and described them and named them Modic changes. And what's inside a Modic change is that you have fractures of the trabecula, and the bone marrow, which is normally producing red and white blood cells, it is now changed, is now fibrovascular tissue, like the same liquid that you have in a blister kind of thing. And then you have ingrowth of hypersensitive pain fibers. And that's why bone edema is very painful, whether it's in Modic Changes or it's in the ankle of an athlete who has been training too much. So it's also called bone bruise or stress fractures and bone edema. That's the same thing.
Okay. And we know that you have different classifications, right, for Modic Changes?
Do we? I'm not sure. It's true that in the original definition, Modic he made 3 types. But nowadays we don't differentiate so much more because it's all a matter of which MRIs you put them in. So I could have a patient that say, "Oh, I want him to have Modic type 1," and I know, "Oh, he should go there and there. There'll be Modic 1." And in another MRI scanner, he'll have Modic type 2. So it's you can see in some Modic Changes you have some fat, some yellow fat, and you have some liquid, and it's like a continuum. You have a little bit of this and a little bit of that, and you MRI the patients 2 years later, and then it changes. It's a continuum. It's not like we have a 1 and a 2 and a 3. It's extremely rare, and I don't think it's any importance.
It's kind of like a progression, like
No, it's not. No. It's how can I compare it? It's like I have a friend. He has psoriasis. This skin disease and he is his elbows, they have psoriasis. Okay, and sometimes when I meet him, his elbows look horrible. They are, liquid coming out, there's oozing, and it's dark red and looks terrible. And then I meet him 3 months later. And then his skin is like slightly reddish, but almost fine. And then I meet him 3 months later again, and then it looks terrible. He has the same disease, but it fluctuates like this. So well, I believe it's the same disease in different stages, but it's not that it's 1, 2, 3 gone. It's not. It doesn't go away.
So it's not like a degeneration that slowly progresses.
No.
Okay. That's what I had in mind when I started reading about it. I was like, well, type 1 and then type 2, it's just like progressively getting worse. That's what I thought when I read. So
everybody thinks so, but it's not true.
Okay. And does it matter for the treatment, like the characteristics of like if, let's say it was the type 1 or type 2, does it make any difference? No. Not relevant. Okay. No. And the only way to diagnose it, is it through MRI?
Yes. And that's why you can say that Modic Changes is a kind of a new disease, because, you have used X-rays for hundreds and hundreds of years, but, MRIs is rather new, and it's more difficult to get an MRI, but it's, so it hasn't really, you haven't been able to diagnose Modic Changes until you had MRIs.
And why did you say that they have different, like, classifications according to the different MRIs? Why would that happen? It's just like different techniques of the MRI. Why did you say that?
Yeah, it's different. You can have a Tesla 0.2 or 0.3, or you can have a 1.1 and a 3.0. And also to make an to make an MRI is really complicated. When I was a child and my parents, they had this camera, and they were they were looking through lens and time and blah, 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 all different kind of things. And today, we just took our iPhone and we take pictures, and it's better than the pictures you took in the old days. And it's the same thing with an MRI. You can twist and turn, and more light here and more dark here, and fat saturated and blah, blah. So it's very complicated to make good MRIs. Mm-hmm. So you can, yeah.
Okay. And so what are the common symptoms associated with Modic changes?
Well, constant pain. They have constant pain. They have most pain in the morning, and then the morning is terrible. It's difficult to get out of bed. Then the pain eases off, during the day, it's still there. It's always there. And then it can, late afternoon, they'll come when they cook their dinner. It'll be horrible, And in the evening, they cannot sit together with their spouse and watch a movie in the television or something, because it's so painful. And the nights are horrible. It's very, very difficult to get a good night's sleep. It's very difficult to turn over in bed. You can imagine the fractures. They go, against each other. And then morning again is painful. So it's what we call a fluctuating disease. Some days are good, some days are bad. It's also very typical that exercises make the pain worse. And that's very hard for physiotherapists to accept, because we are, we brought up with exercises are good, and they are in, very, 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 very most situations. But just when you have this acute period of Modic changes where before they get the treatment, then exercises is not good. So it's very painful to bend over forwards. Movement in the back is painful, and it's very different from other kind of back diseases. Like if you have a derangement, as you call it in McKinsey, for example, you'll have a periodical pain, and then you'll get treatment, and it'll go away, and then the patient will be fine again. It's just like a cold. You can have a cold, and then it's bad for a period, and it's horrible. And then after a while it goes away, and then you have good for a period. But it's never that way with Modic changes. They have continuous pain.
And they are not associated with mechanics. You said that they get worse with exercise, so maybe they get worse with movement, but they never get better. Movement.
No, because you can understand that if you have a fractured ankle, would you do, and no plaster on it, would you do exercises?
No.
That's the same situation.
Mm-hmm. Okay, so I think we skip one important question to help us understand. So what are the potential causes or factors that contribute to Modic changes?
Well, I think that there are three causes. We have the bacteria one, which is the one that I've done research in, and we will talk about it a little more later, I think. And then we have the mechanical one, and you can see that when you have scoliosis and archolysis and things like that, then you have Modic changes there, and that's mechanical, and you cannot help that with antibiotics. And then we have it in rheumatology diseases, ankylosis spondylitis, for example. You will see that they have Modic changes, but they will have Modic changes who are different. They will have what we call shining corners. And naturally, if you have that, you shouldn't treat with antibiotics either.
Mm-hmm. And on that case because you're going to talk about the bacterial a little bit later. So on the case of the mechanical, the treatment is more surgical. That's what you said. Like do you have any suggestions?
Well, I think that, if there's a surgical routine, you can do that. But I think as physiotherapists, we use biostimulating lasers for the patients, because biostimulating lasers, they are really, really good in healing fractures. And in the Modic changes, you have this blister kind of liquid thing. And you also have TNF alpha. And this makes ingrowth of nerve fibers. And laser is really good at removing TNF alpha, and then you have the nerve pain fibers are reduced.
Mm-hmm. Okay. So, and like in the case of scoliosis that you mentioned before, then it's just the way that the pressure is on the bone per se.
Yes, it's more or less.
Then you have to.
They're standing more or less on each other, just like two corners on each other. So
then you have to try to treat the cause per se, try to improve that alignment, which is much harder.
Yes. Okay. And you can do that with exercises. Yeah, probably That's not my specialty, but I don't know. But when we have alkalysis, patients with alkalysis and scoliosis, we treat them with biostimulating laser.
Okay. And how about the rheumatoid diseases that you mentioned before?
We send them to the rheumatologist and get treatment there.
They get the treatment there. Perfect. And then the one that you are most familiar with, so let's talk about that. So how do you know that is bacterial, the cause? You do like a bacterial test, or like how does it work?
No, it's more or less you do it on the patient's history. The patients have had a disc herniation in their history, and when you see the MRI, you'll see a black disc, because the nucleus material has left the disc, and then you see Modic changes in like shapes. It looks more or less like lips, around the disc. If you see like this oncolysis, you'll see like shining corners, and which is completely different from the bacterial one. And then you'll do it on the pain history, and then most of the patients that we get at the Modic Clinic, they've been given up. They tried everything. There's no treatment that they haven't tried, and they have given up, and they have been to the pain center, and the pain center have said to them, just learn to think positively, then your pain will go away and you'll be able to handle it. This is not the right treatment for these people because they have a clear somatic reason. And naturally, they're also depressed and so forth, naturally, because when you've been through many, many years of this, naturally you get depressed. So it's good to think positive, but it doesn't cure Modic changes.
Mm-hmm. Yeah. And then, so you just do the diagnose based on the history. So they have to have a disc herniation.
Previous disc herniation.
Okay.
Yes.
Is that a timeline that you observe that, or no. It varies? No.
No, it's not. It's not that it has to have been within the last 2 years or something. We have treated patients who have had Modic changes for 25 years with success.
Oh wow!
Yeah. So there's not a only 10 years old. No.
Okay. And then they have to have this pain history and this pain kind of pattern that you described previously.
Yes.
And then you combine that with the image finding on the MRI, and that's how you diagnose it.
Yes, exactly.
Okay. And do these patients, they can have like radiculopathy associated with
some of them have
pain or not common?
The Modic changes doesn't give radicular pain. Nerve root pressure gives radicular pain, but Modic changes doesn't. Some of the patients have had a disc herniation with radicular pain, and then the disc has collapsed a little, and then you have a stenosis in the recess, and then you can have pressure on the nerve root, so they can have radicular pain. But Modic changes do not give radicular pain. Modic changes give a very distinct pain. When you say to a Modic patient, please tell me where your pain is, they'll turn around and pull, it's here, it's in here. It's very distinct.
So it's very localized.
Very localized. And when you do the springing test on these patients, they'll go, exactly when you do it on the segment where they have the Modic changes.
And just curious about, how do you differentiate between like a chemical pain that we say, like, so when we are seeing patients, usually we think about chemical and mechanical symptoms. So like chemical, I would say, is just everything makes the patient worse. And then like if they take like a steroid injection, sometimes they get better. So how do you differentiate them between them and like one that could have the bacterial cause that's not going to get better? Maybe they just don't get better with anything, and then that's how you know.
I think that there's some kind of chemical phase 2 in Modic changes because, Modic changes very often destroy the end plate. And you know that a degenerated disc has a pH level of 5.5. And when you have holes through the end plate into the vertebra, you'll have a kind of corrosion which give like burning sensations. And so maybe that's chemical. But I think that chemical pain could, I don't know, we don't differentiate with chemical pain. No.
Maybe it's just like the time the time frame, like usually it's more chronic. You don't see patients in a very acute stage.
No. I think that what you call chemical pain, do they have Modic changes on the MRI? I don't know.
Most people in that stage probably didn't even get an MRI. It's like probably in the beginning of their pain, in like acute stage, first couple months, that they're just inflamed and nothing helps. And then sometimes if you calm down the inflammation, they will respond with movement.
Yes,
but
you never see a patient like that.
Yeah, that's completely different. They just have constant pain that doesn't improve.
Yeah, we are far longer along the timeline than these patients that you talk about. So
yeah. So what is the average of like time that your patients have been suffering with this pain? So I imagine many years.
Around 4 years, 4 or 5 years. That's the average pain since their herniation when they come to us. So naturally, they are in agony and they're having a horrible life. And they can't play with their children, and many of them can't work, and a lot of them are on social security. So it's our patients, they suffer, really. I say that Modic patients, they don't have back pain. They suffer from back pain. It's a very different condition. It is.
Yeah. And have you seen patients that they have the Modic changes on the MRI, but they don't have pain? Or in your experience, they are always associated with pain?
No. There are some Modic changes which are not associated with pain, but they look very different. You will see them, the most patients we have, they have Modic changes in L4, L5, and L5S1, because that's where 90% of the disc herniations are. And then the last 10% is above the last three levels. People who have Modic, and then they have all degenerated discs and, these black disc and protrusions, which is a scar tissue after disc herniation. But we see some people who have like anteriorly, like in the corners on L1, L2, L3, they have perfectly normal discs, and they have like little corners with Modic changes. And they are normally not painful. But we would never dream of treating one of them because they have to have disc herniations in the history, they have to have degenerated disc and so forth. So yes, Modic changes can be non-painful, but they look very different. They're situated in a different place.
Okay, so looking at the image, you can tell if with your experience, if that's the cause of the pain or not, because that's what I was curious to ask you. If how can you be sure that change is the cause of the patient's pain?
When we finish this podcast, I'll send you a few images and you'll see.
We can put some links on the show notes so people can understand.
Yes, it's very easy. It's very easy to see the difference.
Okay. So on those cases, if you look at the image and they have specific changes on the image, you know that they're going to be associated with pain.
Yes. And people, honestly, people don't send their images and go into a lot of hassles if they don't have any pain, Why should they send their MRIs to me if they don't have back pain? Why should they, look for treatment if they don't have pain?
But that's another thing that I think about. So if people, they go to you, they have pain, so they're going to have this difference, the image exam is going to be with these changes most likely. But you never, because it's a difficult question because they don't get to you. Patients that have those changes and don't have pain, you never seen one of those.
No, I've seen them on epidemiological studies, and I have a few patients. I just had the other day actually a patient who had Modic changes, very clear bacterial, and then further up he had also these little ones who are not painful. But when I examined him, he didn't have pain in that area. He only had pain, and the springing test was only positive in the L5S1 area.
How interesting! Yeah.
And I've seen another people who do epidemiology. They find also that people with these Modic changes small shining corners, especially anteriorly, and they don't have any pain with Modic Changes. So, and I honestly don't know what the cause of that is. Maybe, I don't know. Yeah.
And so then how do you know that they're going to respond to antibiotics? Most people respond if they have specific changes on the MRI that you identify. They're going to most likely respond well to antibiotics.
We are very critical at our clinic. We only take about 45% of the people who send their MRIs to us in treatment. So, and they have to have this special pain history, with a disc herniation. They have to have this special pain pattern. If they say, I don't have any back pain, I only have leg pain, we don't take them in. So we're very critical. And the MRI has to be very clear. And then we have a success rate of 92%.
That's great. But that's probably because you have this very rigorous assessment before. So what are the factors that you consider? So you said if they have leg pain, they're probably not going to be good candidates.
Yes, but if they only have leg pain, we don't take them. They must have this very clear pattern of previous disc herniation, disc degeneration, a protrusion we see on the MRI, and then this is terrible in the morning, and then it's get better, and this typical pain history that they tell you.
Mm-hmm. And how about those that you don't give antibiotics? Do you have other treatment options for that group?
Well, sometimes we send them back to where they come from. Yeah, and sometimes we give them biostimulating laser. But it's not, to give 100 days antibiotic is something that you have to be really, really careful with. We only give it to a very small, very specific group of patients. And you have to be very careful. And we have the principle in the clinic, it's better to say no to somebody than yes to too many, because we have to be careful when we give antibiotics in so high doses and for such a long time. So we want to be sure, and to have a success rate of 92%, we think is pretty good, actually.
Yes, yeah, it's very good. So usually it's about 100 days of antibiotics. Do you have a specific antibiotic that you?
No, it depends on what other kind of medicine that they get. So it's a different antibiotics, and then we are extremely careful with the probiotics. In the early days, our poor patients, they were sitting on their toilet all the time, and they had so much diarrhea. It was terrible. And then we had a lady coming over. She's a professor in the biome in the stomach. And she said, oh, wow, yeah, I understand they get diarrhea. And then she said, well, if you give this kind of antibiotics, like one of them, they kill 4 different kind of bacteria. Then you have to have a probiotic, which exactly replace the same bacteria. And we give them in a special schedule. And I tell you, they get a sheet like this, with take this at this time, and then you have to lie down to get the peak, blah, 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 blah. So it's a very strict regime of how to get the treatment. So,
do you have any partnership with doctors that you like? Can you prescribe the antibiotics, or you have to refer them back?
No, we have a doctor working at the clinic.
Oh, nice.
And we also have a very good relationship with GPs. Mm-hmm. So very often we send them, because our doctor, he costs money also, apart from what we charge. So a lot of time we say to the patients, if you go back to your GP, and we have this note, we write, please write this to your patient, and then the GP will do the prescription. So.
Okay. And I know many people probably asked you that before about resistance. I heard someone asking you about that before. So in those cases, because it's so prolonged, do they have any potential like side effects or anything like that?
And now we must separate 2 things. Side effects is different from resistance. Side effects is diarrhea, for example, and then we have control over that. The other side effect, which is the most predominant, is a fungal infection in the vagina. And we help the patients with taking some special probiotics you can put into the vagina if you have problems with this. Very few get dark teeth, like a small fungal infection in their mouth, and it doesn't persist. It finishes after the 100 days, and very, very few patients get increased liver numbers. But that you get increased numbers no matter what you take. So that's side effects, and none of them. Today we can control them very easily. In the beginning, we were not very good at it, but we have improved greatly.
Over the years, you probably learned about the side effects.
We learned a lot. Yes. The other thing is resistance, and there's a kind of knee-jerk reaction as soon as somebody says antibiotics, then ding, resistance. You're getting resistance, but when do you get resistance? You don't get resistance from a prolonged period. You get a resistance develops in bacteria. If you have one infection, then it's put down. Like take in Denmark, we have many pigs in Denmark. This is a huge industry, and pigs are very intelligent animals, and they are bored. So what do? They bite the tails on the ones who are lowest in the hierarchy. In the hierarchy. And then they get an infection. And the poor farmer, he doesn't have time to only give one pig, so he gives it to everyone. And a few bacteria survive, who has developed resistance. And then they get another, they bite the poor pig again. And then they get it, and then again, and again, and again. And this is how resistance develops when you have, many infections, and they get more and more bacteria who are resistant. And in the end, you get resistance. And like in Denmark, the only resistance bacteria, they come from the farming industry. And we have to discuss this matter because that was something we were very worried about. When we began, we talked to Professor Peter Lambert in Birmingham, who has been a wonderful friend and help in all this. And he's a top-notch in all with these bacteria. And he says that, and you have to give this treatment between 22 to 28 times before it's likely that they develop resistance. So far, we haven't reached that number, not even close to anybody. So
and usually on the first course, on these 100 days, they get better? Their symptoms get better?
Yeah, it takes some time. This is a disease you have to be patient in. If you get after the first 100 days, we will only have 50% reduction, and then it gets slowly better. And it takes 2 years before you see the final result.
Yeah, that is a long time.
That is a long time. And that's why we have them in the phone all the time. Oh, Hanne, it's not getting better. Yeah. Be patient, please. It will get better.
Yeah. And do you see difference on their image if they do another MRI? Yeah. So the changes are gone, or like how does? Yeah.
Yeah. In what we've done in the research study, don't do it in normal patients, but in the studies that I've done, we have taken MRIs, 1 and 2 years after, and then the Modic changes are gone. The degeneration persists. We cannot do anything with the degeneration. And that's why they don't get completely cured. We normally take like 80, 90% of the pain away because they also have some pain from the degeneration. But it will go away.
But then they can probably respond to normal treatment.
And that's good because we say the 100 days you are in antibiotics, no exercises. But when the 100 days are over, we give them a very gentle exercise program with focus on inner core. And then we say to them, when you can do this very gentle exercise program, which you can fulfill this without any pain, then go back to your physiotherapist. So we send them back to the physiotherapist they came from.
Okay.
And then they do exercise and training and fitness and Pilates and God knows what. Yeah.
And then do you feel like this rest little bit that's left of pain, can they get better with exercise after?
Yes. Yeah. It's just like normal physiotherapy if you have a degenerated disc. Yeah.
Okay.
That's the same.
Very good. And like if you think about normal population, do you have like a number in mind or something like how common is Modic changes?
Oh, there's been done very, very large studies on this. They've studied, Pierre studied 40-year-olds here in Denmark, where I live, and Jauro Karpinen has studied train drivers in Jyväskylä, and Dino Zamatis at Chicago, he's done the biggest study ever on this. He examined 2,500 Hong Kong Chinese, MRI'd them. And all three studies say that the prevalence is 6%. So, yeah, and that's across races and so forth. So 6% of the population. That doesn't mean that they all have Modic changes from a bacterial reason. They can have it from their rheumatology diseases and from scoliosis and the mechanical and the bacterial thing.
And which one do you feel it's more common between those?
Now I'm guessing. I am guessing that 3 to 4% will be bacterial, and the other will be the rheumatology and the mechanical.
Mm-hmm.
But I haven't done a study on this, so this is my qualified guess.
And so that makes a very, very small percentage of the population that really have the Modic changes with the bacterial cause, and that can be treated with antibiotics.
Yes, and that's true. But the thing is that I know it's a very small population, but the problem is that it's the ones who suffer. Because they are the one. And I remember when I worked as a physiotherapist, I remember having, later on I've recalled back, you have this patient, they come in and they have back pain, and you do this and you do that. And when you're a young physiotherapist, you study all the time thinking, this isn't working, no, I'll try something else. And you try something else and you try something else and it gets worse and worse and worse and worse and worse and worse and worse, And then in the end you think, I'm a bad physiotherapist, I'm not any good. I can't help this patient. But naturally I can't, because these patients, they had Modic changes. I just didn't know that then. And therefore they even though it's a very, very small group, they take up a lot of time with us physiotherapists, and they take up a lot of time with the GPs and with the rheumatologists and everywhere, because they don't get better and they suffer. They are in agony. So I remember them clearly, and I'm sure that you have had some in your practice too. So if you have a patient who doesn't respond to any of the things that you do, don't feel that you're a that you're a bad physiotherapist. It's probably the disease that they suffer that you can't help with. And have an MRI, see if they have Modic changes, and guide them on in the system.
So that's my next question. How PTs can I feel better about or be better at looking at the images and identifying those Modic changes?
It's extremely easy.
Okay. So what do you recommend? Like, do you have resources or like things that people can go and study and read?
It's very, or talk to your at the radiology department, and they can maybe show it to you, or maybe do some courses, or we can make a podcast. Now we'll have to have some images about that to show it. But to see Modic changes is one of the easiest things to see on an MRI. It's very, very simple, very simple.
They need to feel confident that the changes they are seeing are there, and that's the cause. Like you said, like, there are some changes that we know that they don't cause pain.
But a lot of time, the radiologists, when they do the description of the images, they will write Modic changes, or they'll write bone edema or something like that. So that's a good hint, to.
Mm-hmm. Yeah.
So they'll have a look at it and help you.
Yeah. Okay. You don't have any courses?
Let's make one.
Let's make one. Yeah. I think people would, since when you say it seems so easy, so simple.
Yeah.
So, I mean, you've been doing that for so many years. You look and it's like, that's clear.
Yeah. But I'll tell you that they've done studies. I don't know if you know what inter-tester reliability is, so if you do a test on a patient and if I do a test on a patient, then we get the same results, Trade leg raise, for example, that we say this is, abnormal or whatever. And they've done studies with intertester reliability on MRI findings on disc degeneration, on stenosis, archolysis, blah, 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 all different kind of things. And the place where they had the highest intertester reliability, that was Modic Changes, because it's so easy to see. Yeah. Much easier than disc herniation or stenosis or whatever.
Okay, good. Yes. And any advice to clinicians that are starting their careers?
Be curious and listen to what the patients say, because the patients is always right. I worked so many times with patients that I thought, I'm not really sure that's true. But in the end, you find out it's always true.
Yeah.
So, and then be curious and be modest and humble.
Yes. Hey, we talked so much about so many things. That was really, really good. Anything that you want to add before we wrap up?
No, I think it's been pleasant talking to you.
Awesome. And if people want to learn more about you or find you, is there a way that they can reach out?
They can look up my research, and read some of that. But I'm not really a public person like you are.
Not on social media that much, right?
No. I do my research and I take care of my patients. That's all I do.
That's your contribution. It's more than enough.
Just told me that I have to be more on social media, so maybe I will try to listen to your advice and.
Well, I appreciate so much. Thank you for taking the time and share your knowledge with us. I just learn a lot with you, and I know all the audience learn a lot too. So thank you so much.
I hope so. Thank you.